Hi there. Welcome to the new ASAS Case Library case. My name is Denis Poddubnyy, rheumatologist from Toronto, Canada, and today with me is Dr. Hermann from Berlin, Germany. As always, we selected an interesting case for you, and after more than 40 cases dedicated to pure axial manifestations, we thought it would be reasonable to talk also about peripheral manifestations of spondyloarthritis. So here, in this case, we're dealing with a 35-year-old male subject with a several-month history of inflammatory pain in the forefoot, more pronounced on the right side, but also present on the left side. He's suffering from pain mostly at the plantar aspect of metatarsal heads and small toes, more prominent in the lateral aspect than on the medial aspect. And he has pain during both rest and also some weight-bearing activities. In addition to this feet problem, which are currently in the foreground, he is also suffering from intermittent lower back pain for approximately 12 months with some inflammatory characteristics, improving with exercise, no improvement with rest, sometimes also night awakening and morning stiffness that lasts more than 30 minutes. Other than that, no obvious signs of inflammatory disease, no psoriasis, no uveitis, no inflammatory bowel disease, and no signs of preceding infection to suggest potential reactive arthritis. On physical examination, we saw swelling and tenderness involving a small toe in the MTP region, more pronounced on the right side. Also, remarkable plantar forefoot tenderness, again predominantly on the right. No psoriasis, no nail changes, no dactylitis, and no arthritis or enthesitis elsewhere. CRP was clearly elevated, in this case HLA-B27 positive, and other serological markers and lab findings were within the range. So now we have a spectrum of images looking at the axial and peripheral manifestations, and I would like to give over to Kai. Kai, what do we see on the images?
So we have first a set of MRI of the pelvis that addresses the lumbar pain. I believe the MRI was ordered by a non-specialist, as the protocol is not targeted entirely on the sacroiliac joints. It's rather a full pelvis MRI. You can see we have SpA images and T1 weighted images of the entire pelvis, also involving the lower lumbar spine. You can see the hip joints, which look fine. And you, of course, can also see the sacroiliac joints, this here on the T1 weighted sequence, and here on the SpA sequence. We see already some differences in signal intensity. There's this dark appearing area here on the right sacroiliac joint that corresponds to this hyper-intense signal intensity on the T1 weighted scan. This, the left side is characterized by high signal intensity on the SpA sequence that is pronounced actually in the posterior part of the sacroiliac joint. So this is the posterior corner of the sacroiliac joint, the posterior capsule. You see we're very much in the posterior aspect of the joint. And these changes in the sacrum and in the ilium, they are present in almost all slices, also affecting a little bit into the anterior and middle portion, but the very anterior slices, like these ones here, they are normal, which is a good sign that the weight-bearing area or the load-bearing area is not so much affected, which in a way rules out mechanical reasons here in this early evaluation of these images. And corresponding to this high signal intensity, we also have low signal intensity here on the T1 weighted image. But we have more images. So we have two more sequences that I will call up. And in fact, when you scroll through these images, they look almost the same on the first glance. But upon closer inspection, of course, you see that on the left sacral joint, you see a high signal intensity change. And this corresponds to a low signal intensity change here on this image. And also, if you look at this fluid in the urine bladder, you see it's dark here and T1 here. And there's another hint on which sequence is what, and that's the description of these sequences. So here's clearly written T1, here's written T2. So this is a T2 weighted sequence, this is a T1 weighted sequence, but both of these sequences are without fat suppression, which is in fact nothing that is frequently occurring nowadays. But if you have MRI scans from a department who is not so much skilled, or when the images are performed for another reason, for instance, for tumor search, etc., then these T2 weighted images are used, of course. So this is our first set of images. So how would you interpret these images now in terms of also the clinical context, and would you recommend further imaging, Denis?
Yeah, thanks, Kai. I think the point you made is very important one. So nowadays we target for an appropriate imaging protocol of sacroiliac joints, incorporating proper sequences and planes, so STIR, T1, and an erosion-sensitive sequence. In this case, however, I think even with this non-targeted, non-sacroiliac joint targeted approach, we get enough information to say, at least in axial skeleton, it is very likely spondyloarthritis. And we need to interpret also symptoms from peripheral joints, likely in this context. But of course, we would like to know for sure if the problem in the peripheral joints is also at the inflammatory side. So if somebody presents with symptoms like that, what would be your preferred method? Would you go with ultrasound, or would it be a MRI you would suggest as a first-line imaging modality?
So first-line imaging modality in this case would actually be ultrasound. Ultrasound has a very high spatial resolution, has a good contrast for soft tissues that are not obscured by gas or by bone, which is the case actually usually at the toes, and especially at the small phalanges of the distal interphalangeal joints, small MTP joints. You have good access with the ultrasound probe to these areas, and much higher spatial resolution compared to MRI. However, in our case, an MRI was performed maybe for convenience reasons, and what we can see here is again very nice STIR images of the right foot, and also corresponding T1 weighted images. And if we have a look here, one toe sticks out, and this bone is the 5th metatarsal bone. So that's the lateral aspect of the midfoot, forming the MTP joint, which we can see here. And we see also a little bit of bone marrow edema or osteitis in the base of the proximal phalanx of the 5th toe. So it's clearly a joint-centered process. There's maybe a little bit of synovitis or moderate amount of synovitis, but somehow inflammation also extends along the cortex. So we could assume some periosteal reaction as well. So we have a combination of synovial inflammation, periosteal inflammation, and also osteitis. The thickness of these slices is around 2.5 millimeters. So very small erosions are difficult to detect. So here's an axial stack of images. We see the big toe and the phalanges. This is the 5th one. with the bone marrow edema. And if we look here in the head of the metatarsal, it looks quite unaffected, and due to the deformity of the joint, it's very difficult to see here how the joint space looks like. So this would be an active inflammation. So what would be your next step, Dennis, after I would write this kind of report?
Yeah, I think the images are very impressive in this case, and we're also capturing this extensive bone marrow edema, which would not be visible on ultrasound. So for me, there is also some added value. And I know when I see a person like that with a lot of inflammatory activity in axial skeleton, but also in a peripheral joint in this case, that this patient is at risk for structural damage development. So this patient would require rather rapid introduction and intensification, if needed, of effective anti-inflammatory treatment. And in this case, we have also X-rays which demonstrate, I believe, the need for an early intervention in those cases. So in sacroiliac joints,
at the small joints of the hand and feet, X-rays play a role that is quite prominent compared to, for instance, the knee joint or the ankle joint. In large joints, it's very difficult to detect small erosions, also due to the large structures in the many different aspects of the bone overlapping. But in the hand and feet, at least from my experience, we have very small joints, and the spatial resolution of X-ray is extremely high. So we can see defects in the bone in a very good manner. And if we look here at the enlargement of these two X-rays, we can see clearly there's an erosion over here. It's the fifth MTP joint on the left side. Here's the marker for the left. Also maybe a small erosion here. But we did look at the right foot with our MRI. And we can see there's some soft tissue swelling here, and also there is some initial destruction of the bone. And if we look at the MRI again, so this is exactly this same extremity, 6 months apart. And we need to remember always to correctly label the MRI images, because the slices in the MRI are defined as we look onto such an axial slice from beneath the patient. So this would mean that this is actually the right foot, and we are looking from the sole of the foot into this joint. So this is actually the fifth MTP joint on the right, which is corresponding to this X-ray here. And therefore, we can say that this extreme inflammation is reflecting here with this soft tissue swelling, but also already creating this erosion-like change, which was rather difficult to appreciate here. Maybe there's some signal loss here. So we don't have a thin sliced wipe sequence of the foot, which we would do in our institution, but this was not done in this outside MRI examination. And also to finalize this case, an Ferguson X-ray was performed, and here we could see there are these erosions actually that we did not really discuss in our T1 rated MRI, but here we see these are erosions, so I would be sure that there are also structural lesions on in these patients on the sacroiliac joint. So this would be my summary. So how do we come together with this case, Dennis?
Wonderful, Kai. Thank you very much for all the imaging explanations. I think it is an important case, stressing the relevance of inflammation in the peripheral joints. Even in axial spondyloarthritis, we know that there are substantial differences in the geographic distribution of peripheral inflammation. And I believe in the following cases, we will be talking more about peripheral arthritis and enthesitis. So stay tuned and see you next time.
Thank you, Dennis, for moderating this case, for presenting the clinical picture, and all of you, thank you for learning with the ASAS Online Case Library about this interesting set of diseases. And for those who are interested, all of these cases also have a written text summary. So while you learn, you can also read and review the cases and the imaging features. Thank you, and bye-bye.